Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today we will talk about another head and neck space infection, that is retropharyngeal space and its infections. Uh, we have already talked about peritonsillar space and parapharyngeal space, and the links for those, they are there in the description, so you can check it out, those links as well. And this retropharyngeal space infection, which we call as retropharyngeal abscess. So before embarking upon today's video, you are requested to subscribe, like and share the channel. So this is the diagram, cross section at the oropharyngeal level. So to understand the anatomy of parapharyngeal, peritonsillar space and retropharyngeal and prevertebral space, so this diagram is very important. When I was discussing the parapharyngeal space anatomy, the same diagram I shared. So today again we will focus on this one, and this is the tonsil, you can see, and this is the peritonsillar space, then is these constrictor muscles of the pharynx, and then is buccopharyngeal fascia, and lateral to that is the parapharyngeal space. So this is the parapharyngeal space, which is divided into anterior compartment and posterior compartment by the styloid process, and posteromedial to this parapharyngeal or lateral pharyngeal surface space is the retropharyngeal space. So this is the retropharyngeal space on the right side and left side. This retropharyngeal space immediately posterior to the pharynx, it is divided into two spaces of gillette by the midline fibrous raphe, and it contains the lymph nodes of Rovier, which usually disappear around the age of 3 to 4 years. And its boundaries, as you can see, anteriorly is the posterior pharyngeal wall. So this is the posterior pharyngeal wall, and it is the buccopharyngeal fascia which is forming the anterior wall of this retropharyngeal space. Posteriorly is the prevertebral fascia. Superiorly, above, it starts from the skull base, and inferiorly it goes into the mediastinum till the bifurcation of the trachea. And laterally, of course, is the lateral pharyngeal wall or parapharyngeal space on this side, and parapharyngeal space will be there on this side as well. So in the cross-sectional area here also, you can very clearly see that this is the prevertebral space and this is the retropharyngeal space. So this is very important to understand. Prevertebral space, which is there between the alar fascia and the prevertebral fascia, and this retropharyngeal space, which is between the buccopharyngeal fascia and posteriorly is the prevertebral fascia. Actually, retropharyngeal and prevertebral spaces both are behind the pharynx. Immediately posterior to posterior pharyngeal wall is retropharyngeal, and then behind retropharyngeal is the prevertebral space. These retropharyngeal abscess, these are of two types: acute retropharyngeal abscess and chronic retropharyngeal abscess. Acute retropharyngeal abscess is commonly seen in children below 5 years of age because it is the result of suppuration of nodes of Rovier or posterior pharyngeal lymph nodes, which usually disappear around 3 to 4 years of age. So of course it will be there only below that age. And that infection which comes there, it is usually coming from the upper respiratory tract infection, that is from the tonsils, adenoids, nasopharynx, posterior nasal sinuses or the nasal cavity. And in adults, this acute retropharyngeal abscess, it may result from the penetrating injury to the posterior pharyngeal wall or the cervical esophagus. Rarely pus from the acute mastocytitis, it tracks along the undersurface of the petrous bone to present as retropharyngeal abscess, or it may be any surgery in that area, and due to post-surgical infection the abscess can form there. While the chronic one, it is tuberculous in origin, and this tuberculous in origin, it is usually in the prevertebral space. Now prevertebral space is different from retropharyngeal space, and usually in adults, and that is secondary to caries of cervical spine or tuberculosis of the cervical spine. But if it occurs there in the retropharyngeal space, then it will be the tuberculous infection of the lymph nodes there. So in children, in retropharyngeal space, if it is a chronic retropharyngeal abscess, that will be due to the tuberculosis of the lymph nodes of Rovier, which are there secondary to cervical lymph node tuberculosis. While in adults, again I am reiterating, it will be infection, chronic abscess formation in prevertebral space, and that will be due to the caries of cervical spine. So in acute retropharyngeal abscess, it is usually preceded by upper respiratory tract infection, and usually it involves the younger children, less than 5 years of age. Dysphagia and difficulty in breathing will be the prominent symptoms. Even stridor and croupy cough may be present. Hyperextension of the neck leading to torticollis. Muffled voice will be there. Voice will not be hoarse, but it will be muffled voice. Patient will be febrile, ill looking, with drooling of saliva. There will be bulge in the posterior pharyngeal wall. This bulge will be there in the posterior pharyngeal wall, and it will be unilateral on one side of the midline, not exactly in the midline, because retropharyngeal space, as I just mentioned in the diagram as well, that retropharyngeal space is divided by a midline fibrous raphe into right and left spaces of Gillett, and there the lymph nodes are present. So if there is suppuration of those lymph nodes, the swelling will be there in the posterior pharyngeal wall on one side of the midline. Then there can be tracheal rock sign. And what is this tracheal rock sign? This is the pain felt by the patient while gently moving the larynx and the trachea from side to side. If you are just like laryngeal crepitus, if you are moving it just from side to side gently, there will be pain. So this is what we call as tracheal rock sign in case of acute retropharyngeal abscess. So of course we will go for investigations, then CBC, that will show us leukocytosis in case of acute infections with polymorph nucleocytosis. Now plain X-ray soft tissue neck lateral view is one of the important investigation, radiological investigation in case of suspected retropharyngeal abscess. And how we have to interpret this X-ray is that the distance from the anterior border of the cervical vertebra to the posterior border of the airway, there will be soft tissue shadow due to perivertebral muscles, and this shadow will be less than 7 millimeter at the level of C2, and it will be less than 14 millimeter in younger children. And so if this soft tissue shadow is widened more than normal, or it is more than 2/3 of the corresponding cervical vertebral body, it is significant that some soft tissue abnormality is there. And if history and examination depicts, then it will be retropharyngeal abscess. Or we can go for CT scan, plain and contrast, to see the extent of the abscess and involvement of the blood vessels as well. So in this is X-ray soft tissue neck lateral view. If you can see that this is the airway, where the air on plain radiographs and on CT scan, it will be jet black wherever there is air. So this is the airway, and here you can see the shadow and this is the cervical spine, of course. So between the anterior border of cervical spine and the posterior border of this airway, you can see how much large distance of this soft tissue density mass is there. So that's what I was mentioning, is that if it is more, this is the cervical vertebral body. So if the shadow in front of the corresponding cervical vertebral body, it is more than 2/3, it is significant. And here you can see it is even 3 times or 4 times more than the vertebral bodies. So that is significant. And here you can see air bubbles are also there. So most probably it is a retropharyngeal abscess. And CT scan will give us more detail, of course, and the extent of. So again, here you can see that just in front of the vertebral column there is air, and below is the fluid. So air fluid level, wherever there it is, that is signifying that some pus formation has already occurred. And again you can see this is the anterior border of cervical spine, and this is the airway, and the distance between the anterior border of vertebral column and posterior border of air column, you can see it is more than 3 times 4 times of this vertebral body diameter. So it is significant here. Again, air fluid level is there here, and here significant airway shadow is increased, soft tissue shadow is increased, and this is on CT scan. You can see the pus formation there. So there can be complication just mere the size of the abscess. For example, if this is huge size, there mechanically it can obstruct the airway. So airway problem can be there. Dysphagia or odynophagia may be there just because of its mass effect size. Then it can rupture and the pus can trickle down into the airway. So there can be aspiration, pneumonitis or lung abscess can form there, and then there can be spread of infection from retropharyngeal space to parapharyngeal space or to peritonsillar space or to other adjacent spaces of head and neck. So complications can be airway obstruction, aspiration pneumonia, acute mediastinitis. It can spread to danger space and other neck spaces, spontaneous rupture, septicemia, and even death can occur. So hospitalization is very essential. You have to go for intravenous fluids for hydration, triple regime antibiotics. When we say triple regime, it means intravenously high dosages antibiotics which are covering the gram positive, gram negative, and anaerobes. For gram positive cover, either we have to choose the first generation cephalosporin or we have to go for penicillin and its derivatives. For gram negative coverage, either we have to go for aminoglycosides, or nowadays we prefer third generation cephalosporin with less risk of side effects, and for anaerobes we have to go for metronidazole. Then strong analgesics are required, and pus has been formed anywhere, we have to drain it. So we will go for incision and drainage. This incision and drainage, either it can be transoral, and transoral we have to give the vertical incision in the posterior pharyngeal wall with sinus forceps. We have to open the cavity, we have to drain the pus, or we can go if it has trickled down or it is a large collection of pus which cannot be evacuated from transoral route, then we have to think about the transcervical incision from external approach. In a transoral approach, under anesthesia, you have to go far. Then the patient's head should be a bit low down so that there is no chances of aspiration. And then you give a vertical incision along the posterior pharyngeal wall and you remove whole of the pus. Now, chronic retropharyngeal abscess, it is also, called as prevertebral abscess. If it is there in the prevertebral space, it is tuberculous in origin. This is must, that chronic abscess, it is tuberculous, either it is there in retropharyngeal space or it is there in the prevertebral space. If it is there in the prevertebral space and it is seen in adults, and it is due to the tuberculous caries spine, tuberculosis of the cervical spine, and on examination there will be a swelling or bulging of the posterior pharyngeal wall which will be there in the midline, in the center. While in case of retropharyngeal lymph nodes, it will be there in younger children, because we know that nodes of Rovier are there up till age of 3 or 4 years, and after that they vanishes. So if chronic retropharyngeal abscess in children, it is there, it is due to the tuberculous lymphadenitis, and there will be other cervical lymph nodes also involved due to tuberculosis, and there the swelling will be limited to one side, because retropharyngeal space we know that is divided into two parts by a midline fibrous raphe, and lymph nodes are present on either side of the midline, and the suppuration of those lymph nodes will lead to the swelling on one side of the midline. So on examination this will be a differentiating feature whether the swelling or abscess formation, if it is there in the prevertebral space or it is there in the retropharyngeal space. As I have mentioned already, these two spaces, they are posterior to the posterior pharyngeal wall. So first is the posterior pharyngeal wall, just behind that is the retropharyngeal space, and behind retropharyngeal space is the prevertebral space. So this prevertebral space, it is a potential space between two layers of prevertebral fascia, that is the alar and prevertebral layers. It extends from the skull base and it goes along the whole length of the vertebral column up to the coccyx. So while the retropharyngeal space, it is there only up to the bifurcation of the trachea. Retropharyngeal space is also starting from the skull base, but it goes into the mediastinum up to the bifurcation of the trachea, while prevertebral space is more longer and it runs along the whole length of the vertebral column because it is prevertebral, in front of the vertebra. So it starts from the skull base and it goes up to the coccyx. It can lead to mediastinitis and infections similarly to retropharyngeal space infections. So there will be discomfort in the throat, dysphagia, which will not be that much marked as it is seen in acute retropharyngeal abscess because this is a chronic infection. And posterior pharyngeal wall will show us a fluctuating swelling centrally if it is there in the prevertebral space, or on one side of the midline, especially in children, if it is there in the retropharyngeal space. And neck may show other cervical lymph node involvement, that is the tuberculous lymph nodes may be there, especially in children. So it is a lateral type. When we say lateral type, it means that it is in the retropharyngeal space. It is there in the children due to the suppuration of the nodes of Rovier. So one side, so that is what we call as lateral. So it is called as Cox infection of the cervical lymph nodes spreading to the retropharyngeal nodes and forming a cold abscess. Cold abscess is in tuberculous. It is seen in children below 5 years of age. Swelling seen intraorally is classically on the side and not in the midline, as there is a central raphe. I am mentioning it again and again. And swelling is fluctuant with minimal congestion or signs of with minimal signs of inflammation. While other one will be central type, of course, which is Pott's tuberculosis cervical spine. So it will be there in the prevertebral space between the body of the vertebra and perivertebral fascia. It will be present. It begins in the middle and spreads to both sides. So more bulge will be there exactly in the midline, and it will be seen in adults secondary to tuberculosis of the cervical spine. And on oral examination, there is a swelling in the midline in the posterior pharyngeal wall, which is fluctuant with less signs of inflammation. So CBC, there will be leukocytosis, and lymphocytosis. ESR will definitely be raised. Ultrasonography of the neck and aspiration can be done for ZN staining, and ultrasonography of the neck will show us whether it is retropharyngeal abscess or prevertebral space abscess, and other cervical lymph nodes also will be evident on ultrasonography of the neck. X-ray soft tissue neck lateral view will show us, this soft tissue density shadow in front of the cervical vertebra more as compared to the normal one, that will be more than 2/3 of the diameter of the corresponding cervical vertebra. I show you the x-rays as well. CT scan of the neck will show us the site and extent of the abscess. So x-ray soft tissue neck will be showing us, as you can see here in this picture as well, that there will be soft tissue density mass which is increased in front of the corresponding cervical vertebra. At any level, it is more than the 2/3 of the diameter of the corresponding cervical vertebra. Here also we can see the abscess formation there in front of the cervical vertebra. So hospitalization is must. IV fluids for hydration, IV antibiotics for superadded infections, because specific treatment will be anti-tuberculous therapy, so any wide spectrum antibiotics. Then incision and drainage, again just like acute abscess, paroral or externally transcervical incisions, analgesics, and then anti-tuberculous therapy is must. Anti-tuberculous therapy, the medical people or pulmonology people, they will talk about in detail, and you will refer to those books as well. And there are different regimes. There is 6-month regime, there is a 9 months regime, so accordingly we have to follow that. And then we know that there are so many drugs, anti-tuberculous drugs, which have to be used simultaneously, so the compliance is a problem, because the patient has to take so many palm full of these tablets daily has to take. So instead of that, there is a combination of drugs are available. So those combinations can be used. Very simple regime is that for 10 kg body weight, there is one tablet of that combination of those anti-tuberculous drugs. So for example, if a patient is 40 kg, so that patient has to take only 4 tablets of that combination of anti-tuberculous drugs once daily. And along with that, of course, we have to give the patient about multivitamins and folic acids as well. And patients, renal function tests should be done before the start of antituberculous therapy. Eye examination should be there before the start of antituberculous therapy, and then liver function tests should also be there as a baseline, because these antituberculous drugs have got their own side effects. So if this retropharyngeal abscess is left untreated, or prevertebral abscess is left untreated, there will be, of course, a respiratory obstruction, then spread of the abscess to other adjacent neck spaces like parapharyngeal space or carotid space, then septicemia and even death can occur. So with that, we come to the end of today's discussion. You are requested to like, comment, and share the channel with your friends so that they should also get benefit from these videos. And you are requested to subscribe the channel as well. Thanks for watching.